I would request the chairpersons, Dr. Robin Thambudorai, Sudhir Ovi, Vishal Gupta, and Dr. Florian to please come on the chair.
Good morning, everyone. So we start today's morning session. The first session is by Dr. Rohit Dama, and he is speaking on Redo-fundoplication. Rohit Dama, please.
Good morning. I'm going to present about Redo-fundoplication. Basically, this is two short videos. The first patient had fundoplication done out elsewhere and presented with dysphagia. He was extensively evaluated and endoscopy was practically normal. There was no reflex documented on the 24-hour pachymetry. He was labeled as functional heartburn. CT chest and thorax both showed minimal dilatation. Manometry had shown ineffective esophageal motility. Now this patient had a manometry done even pre-operative, which was normal. He underwent a barium. Now they showed some mild narrowing, which was suspicious of a tight trap, but practically it looked like normal only. So he underwent surgery. So as expected, there were some adhesions. Usually the left lobe is the one which gets adhered to the wrap area, including adhesions onto the greater curve. So here the idea is to open the lesser sac and release the adhesions from the left lobe of the liver. We probably need both blunt and sharp dissection. A gauze piece is very handy. Once you identify the area of the wrap, we try to dissect the wrap and try to separate it from the abdominal length of esophagus which had been used, and the wrap had been done on that. This stage, the idea is to get onto the upper border of the wrap. So once you do that, one option of using a staple, a GI 45 can probably be used to transect the wrap. This case we continued with the dissection because the upper limit we were not able to define clearly. So these were the stitches of the wrap, and once we are clear that we are cutting only the tissue in between, we can use scissors. So this part of the surgery remains the difficult part. You need to see that you don't injure the abdominal length of the esophagus while unwrapping. So because this patient had difficulty in eating, the plan was to first unwrap the fundoplication and then take a call. So this was one of the last stitches that was removed. And finally, we can have the wrap separated both on the lesser curve and the greater curve side. So usually these patients, we do an on-table endoscopy. Now that is going to help us to decide how effectively the wrap has been undone, and do we need to do anything more or we stop at that. So because the predominant symptom was dysphagia in this patient, we first undid the whole wrap. And this is an on-table endoscopy which did not show any abnormality as such. There was no hold up. It was going in freely. This is a real-time picture where you can see both endo and the laparoscopy view on a single screen. So that helps. So it was a snugly fitting wrap, only the posterior part was remaining because we had undone the wrap anteriorly. So we presume at this stage that probably the crura was good enough and that need not be handled. So a decision to just unwrap the previous wrap was taken. So this is the endoscope showing quite snugly fitting wrap. There was no narrowing hold up. So effectively what 360 wrap was done, we undid that, and what we tried to do was create a 270 or a 180 degree wrap. So the posterior part of the wrap was not dissected, and the wrap was then fixed on the right side with 2 silk sutures. So basically these procedures, we need to understand what is the problem post-operatively, what exactly is the patient's issue, and for that on-table endoscopy is a great help. We also use a 38 French bougie intraoperatively. I'll show you in that video. So that's the upper stitch being taken. Now this is the 38 French bougie which we have passed after taking the first stitch to see that it is adequately opened up. So that's the wrap on the left side. That's the abdominal length of the esophagus, and the bougie moves in and out freely. So for this patient we just converted the 360 to a 270 degree wrap. So this is a stitch on the wrap on the right side. And once again we confirm with the bougie being taken in and out. So this second patient, he had a hiatus hernia for a few years, was operated outside. This patient presented with post-operative persistent vomitings. They were more of vomitings than reflux, and upper GI then still showed a hiatus hernia. CT was normal, manometry also was normal. So this patient had significant adhesions, colon, stomach, everything looked stuck, left lobe of the liver. So we had to do extensive adhesiolysis first to define the stomach. So in redo, this is one of the problems. Here the previous surgery operation notes had mentioned about mobilization of the GE junction also. So maybe dense adhesions. That's a suture we can see which was stuck to the liver. So sharp and blunt dissection, define the greater curve. Again we did an on-table endoscopy because we thought probably these adhesions were causing kink and they were the cause of vomitings. But as we did an endoscopy pre-operative also and the endoscopy done on table, both this showed a persistent hiatus hernia. So the Ryle's tube was removed and this is the on-table endoscopy. So this showed still there was a significant amount of hernia and very lax GE junction. And when we retroflexed and saw there is a huge gap like grills 3, grill 4. So it was decided that this patient needs to undergo a crural repair for the repair of the hernia. Here the caudate lobe is a very important landmark. Usually it is stuck because of these adhesions, but once you identify that, your right crus is just next to it, and that serves an important landmark to define the crura. Similarly, we are trying to define the crura on the left side. And once both the crura are defined, we take the control of the GE junction. We can use a umbilical tape, but what we normally use is a Foley's catheter. So then with the traction, we do the intrathoracic mobilization to get adequate length of the esophagus. Probably no crural repair was done in this patient. So relatively, there were less adhesions at the area of the crura, and they had put some stitches on the stomach. I don't know what type of repair was attempted. So then we try to close the crura. Usually we use 2,0-ethibond. Up to 3 stitches are normally enough to give enough closure of the crura. And since we had mobilized enough, we could take that bulge is because of the bougie again, and we completed a 360-degree wrap. So the first stitch we usually take the esophagus, so that sort of fixes the wrap. Usually about 3 stitches are enough to create a nice floppy 2-centimeter wrap. The wrap is then fixed to the right crus again to prevent migration. And for removing the Foleys, we again check with a bougie. It's a 38 French bougie, which we check that it goes in and comes out freely. So summarizing, these are difficult operations, should be offered after proper evaluation, and need to select our patients properly. Both intraoperative endoscopy and intraoperative bougie are a great help when you are doing redo procedures. Patient needs to be explained about open surgery, preferably should be done in high volume centers. So that is one of our redo patients. Thank you.
Thank you, Dr. Dama. That's a good video. So, yeah, we agree that there will be a lot of additions in a redo-fundoplication, and the key thing is that you have to identify the crurae first, the both and left and right crura, and then dissect. Now, what was your, when did you decide on a redo surgery in your first patient, dysphagia? So, many of patients after fundoplication presents with dysphagia. So, when you take this patient for surgery?
So, these patients who come with problems after a fundoplication surgery, they need to be evaluated quite extensively, and we really need to sort out what it is, what is the problem. So probably they need a repeat, first an endoscopy, if required a manometry, a 24-hour pH study, and a CT scan to look at the anatomy, whether there is any problem with the wrap, whether there is a slippage, and what exactly is troubling the patient. Like the first patient we did had a effectively normal endoscopy. Even the barium didn't show significant stricture, but symptom-wise, patient was quite, he was quite troubled with his symptoms, and he said he has been having problems to that extent that he had stopped his work. He was from Indian, settled outside. So for 8 months he had stopped his work just because of the problem of eating. So I think we have to go by the symptoms. And then when we decide to reoperate, we need to decide what exactly is the issue. And that's why one patient, we didn't do the crural repair because it looked adequate on endoscopy. And the second patient who had more of vomitings. So initially we had thought we'll just put in a scope and look whether there is any other, we didn't show in the video, there was significant adhesions onto the pyloric side also. So there was a doubt whether those are the ones which are causing vomiting. So after separating all that, on-table endoscopy still showed a hernia. So that is the time we have to do the redo. So many decisions we might have to take intraoperatively.
Dr. Rohit, Dr. Bedier.
Sir.
Hi. A nice demonstration. This one thing, many times it's been seen that fundoplication has been done in where it was unindicated.
Yeah.
Many times it has been non-ulcer dyspepsias or the symptoms. So I think going back before taking up these patients for resurgery, we should be going into the history that before the patient was taken for a first surgery, what were the symptoms?
Yeah.
And many of them are sort of an emotional wreck, where these symptoms will keep on persisting, whatever you may try to do. Like you said, everything was normal and you go in. So with all this gamut of investigations, I think history is very important, whether there is a psychological aspect or to it or not.
Yeah.
Thank you.
So before doing redo, we offer all other, suppose we find that there is some hold up and patient has dysphagia, option of endoscopic dilatations. So all these things are looked into. So you should really be sure what you are doing and select your patients very carefully, both even during the primary fundoplications also, and if the situation of a redo arises.
Dr. Dama, very nice videos. I just wanted to ask about the first patient. That barium and the fact that his motility studies showed ineffective motility.
Yeah.
Could he have also had an esophageal motility disorder? And was anything done
So
to
we looked into
investigate
his
that further?
previous thing. He had a normal motility report done, which was done before surgery. One, he had one more motility report, which was reportedly normal. That was done at some other place. So we were really not sure about the motility report, but patient had significant symptoms. He is almost like, he says, I want to get my wrap undo. Maybe there was some psychological element also, but apparently post-operatively he's been doing well.
Okay, I think last question from Dr. Inian, and then we'll move on to the next.
Thank you, Dr. Dama. Excellent video. For these redo fundoplications, obviously you did not use a mesh, but what is your recommendation? I mean, with using a prosthetic mesh for the crural repair. When do you decide it, and what mesh do you use, if at all you're going to use it?
Yeah, we've used meshes a couple of cases, but they were not redo. They were done for primarily fundoplications. So it depends. If you're doing the fundoplication because of a frail wrap or a slipped wrap and a wide crural opening, and which is quite, the tissue is not good enough for crural closure, and you feel it's going to give way. So maybe those cases we can think of putting a mesh for redo fundoplications.
And what's your personal preference, if at all? What type of mesh do you normally use or recommend?
What we use is the coated meshes, the one which has that, what we use for IPOM. We tailor make it and use that. We have not used in redo fundoplications. We've used a couple of cases in primarily ones where the hiatal defect was huge.
Sure. No, there's about usage of biological. First of all, I guess mesh is not necessary. Most of the time, you should be able to bring it together without a mesh. And biological meshes, the problem is the cost, the exorbitant cost. So basically, we use, if at all, a dual mesh for the repair.
So the two cases we've done, we've used dual mesh.
Yeah, quite often mesh also would be needed when the crura is so apart and very, very fragile, especially in an elderly patient. Recently, we had to do a surgery like that. Yes, the previous barb mesh, which is custom made, that mesh for fundoplication is not available anymore. So we use dual mesh, cut it, shape it, and fix it.
Sure.
Thank you.
As long as the crura sort of fibers are sort of not, disrupted, generally you should be able to bring it back together without a mesh. I guess that's the truth. Thank you.